Hi, my name is Eric Guo. I am from the Headway School in Oakland, California, and I am going to present my research on the prediction of respiratory syncytial virus associated hospitalization using machine learning models based on environmental data. So RSV is a respiratory virus that causes acute respiratory infections. It is transmitted through airborne particles and via direct or indirect contact. Once infected, it can lead to cold-like symptoms and even severe illnesses like bronchiolitis and respiratory tract failure. Globally, RSV has a major impact. Each year, there are 33 million people getting RSV lower respiratory tract infections, leading to 3.6 million hospitalizations and 100,000 deaths among children under 5. In the United States, there are approximately 58,000 to 80,000 hospitalizations annually among children under the age of 5, according to the CDC. So overall, RSV represents a significant global and national health burden in young children. So in recent years, many studies have investigated the relationship between atmospheric conditions and RSV infections. For example, in Susa, Tunisia, RSV infectivity was found to be negatively correlated with temperature and humidity. In the United States, precipitation and temperature were identified as correlated factors. In addition, researchers in China showed a significant predictive effect of nitrogen dioxide levels and other meteorological conditions. However, these studies also currently have limitations, including small data sets, restricted geographic range, and limited generalizability across contexts. So the objectives of my research are the following. First, to pioneer the integration of wastewater surveillance and environmental data to predict disease spread at a national scale. The second is to develop a machine learning model to predict US RSV-associated hospitalizations using multi-source national surveillance data. And third is to help healthcare systems to better anticipate and prepare for outbreaks. So the response variable of our model was the weekly rates of laboratory-confirmed RSV-associated hospitalizations, which were collected by the CDC RSV Hospitalization Surveillance Network, RSVNet, by conducting population-based surveillance in 13 states across the US. The weekly rates show how many people in the surveillance state are hospitalized due to RSV every week, compared to the total number of people residing in that area, and the unit for this is the number of hospitalizations per 100,000 persons. It is categorized into 3 categories: low risk, alert, and epidemic. So the predictors for the model come from 3 different sources of national surveillance data. So first of all, we know that infected individuals can shed pathogens in their stool and urine, which end up in wastewater treatment facility plants. National Wastewater Surveillance System, the NWSS, monitors the wastewater viral activity level, WVAL or WVAL, of RSV weekly. Wastewater monitoring can detect RSV spreading within a community earlier than clinical testing, even before infected individuals seek medical attention. Daily meteorological data was obtained from the NASA Power Project, a highly accessible and high-quality data set from satellite observations and models. Daily outdoor air quality data were collected by the US Environmental Protection Agency. So I did some data exploration before developing the machine learning model. The overall weekly rate across the 13 states was visualized over time by age group. Overall, the time trend showed the seasonal patterns of RSV-associated hospitalizations, which typically occurred between November and April, and peaked during the winter season each year. However, the unusual pattern was observed during November 2020 and April 2021, which was that there was no RSV epidemic that year. This deviation was likely due to the fact that around that time, CDC first recommended a public mask mandate to prevent the COVID-19 pandemic, which also prevented the transmission of other airborne infectious diseases such as RSV. As you can see, there are significant differences among age groups. Children 0 to 4 years old were the most affected and had the highest rate, which means they were most impacted by RSV and thus were used for further model development. Similarly, significant difference exists between race/ethnic groups in the United States. American Indians and Alaskan Natives, AI/AN, had the highest rate of hospitalization. Based on literature, indigenous populations are more likely to be displaced from their ancestral lands and face poverty, poor living conditions, and a disproportionately high percentage of indigenous families live in overcrowded housing with poor ventilation, which facilitates the spread of respiratory infections. Additional risks include malnutrition, limited access to clean water, as well as poor sanitation, further jeopardizing overall health and increasing the infection risk. So, a machine learning framework is developed to help prevent these things by predicting national RSV-associated hospitalizations, enabling real-time and precise assessment of these hospitalization trends and the potential stress on the healthcare system using national surveillance databases. 3 machine learning approaches, including classification and regression trees, known as CART, random forest, and boosting, were evaluated to identify the best performing model to use for prediction. Data from these national surveillance systems were then used to predict the outcome 3 weeks later. So the data was split into 2 parts, 80% of the data for training and 20% for testing sets. We used a 10-fold cross-validation to train the models, and model performance was evaluated based on the following metrics. Number 1, prediction accuracy based on the confusion matrix in the bottom left, which shows the concordance between predicted/actual. Number 2, the F1 score. Number 3, the AUC of the ROC curve, or the area under the curve of the ROC curve on the right, which plots the true positive versus false positive rate. So when we used the CART model, we actually had some interesting findings. The selected tree, as you can see in the picture, which shows the splitting variables and the classification probabilities for each class. The first split was based on W-val, which is to be expected, with observations below 4 being further classified by ozone. For observations with the W-val greater than or equal to 4, however, the second split is based on surface pressure, with a cutoff of 98 kilopascals. So why does surface pressure split our tree? So it's found that 3 states in our data set, Colorado, New Mexico, and Utah, are high altitude states and have a lower surface pressure, less than 98 kilopascals, but higher hospitalization rates than other states. In the model, surface pressure served as a geographic indicator to represent regional variation in the risk. After the data from the 3 states was removed, the tree no longer has a split by surface pressure. Lower pressure in these elevations resulted in less oxygen in the air. For young children infected with RSV, reduced oxygen levels made their illnesses worsen and increased the risk of hospitalization. So among the 3 models, the random forest achieved the highest prediction accuracy and the F1 score, indicating the best overall performance out of the 3 models. Its area under the curve values were slightly lower than those of boosting for low and epidemic, but higher for alert. Boosting showed its slightly lower prediction accuracy and F1 score, while CART ranked the lowest among the 3 models. Variable importance analysis were generally consistent, with W-val identified as the most important predictor, followed by other variables such as ozone, RH2M. Compared to boosting, random forest is generally more robust to noise as well as overfitting due to its use of independently constructed trees and its less hyperparameter tuning, resulting in a stable performance across datasets. So we selected the random forest model for our further analysis. So in order to actually apply our model to everyday use, we developed an R-Shiny dashboard to allow users to predict the weekly rate of RSV-associated hospitalizations. Users can select a specific state, like the one they live in, and input wastewater RSV level, W-val, and other meteorological variables, as well as air pollutant concentrations, by using the sliding bars for each variable. The predicted risk would show up on the US map, and the dashboard provides a real-time risk prediction and visualizes the trends over time for the selected state, making it a practical tool for public health planning and early warning of potential hospitalization surges. So, to conclude, some of the things we learned from this research, we were able to demonstrate the first type of machine learning model to leverage multi-source national surveillance data to forecast RSV outbreaks up to 3 weeks in advance. We developed a machine learning framework that is adapted to predict hospitalizations for other infectious diseases like influenza, SARS, and COVID-19, and we developed an R-Shiny dashboard for practical use to help healthcare professionals better prepare for pandemics. However, there are still some limitations, as the machine learning model was developed specifically using data from children aged 0 to 4, so additional validation is needed for other age groups. Also, the machine learning model was only based on US surveillance systems, which may not be applied to other countries. And lastly, disease outbreaks were also related to socioeconomic factors, which were not included in our model. So in order to better our model, we would develop a real-time monitoring system that continuously integrates updated wastewater, meteorological, and air quality data, and further investigate the causes of elevated hospitalization rates among American Indian and Alaska Native populations and in high-altitude states. Here are my references. And thank you for listening.